Welcome to this comprehensive Internal Medicine MCQ revision session. In this presentation, we will cover 60 single best answer questions with detailed explanations, carefully selected from high-yield topics. These questions are ideal for final year MBBS exams and equally valuable for international exams such as USMLE, PLAB, and MRCP Part 1. Each question will be explained in depth, not just the correct answer, but also why the other options are incorrect. So get ready to test your knowledge, sharpen your exam technique, and strengthen your clinical reasoning. Let us begin. Question 1. A 65-year-old man with chronic kidney disease presents with muscle weakness. His ECG shows tall tented T waves, absent P waves, and broad QRX complex. Which of the following is the most appropriate immediate treatment to stabilize the myocardium? Calcium gluconate, insulin with dextrose, sodium bicarbonate, salbutamol nebulization. The correct answer is calcium gluconate. The patient has ECG changes of hyperkalemia. The very first step is to stabilize the cardiac membrane. Calcium gluconate acts within minutes, preventing life-threatening arrhythmias. Insulin with dextrose shifts potassium into cells, but it takes 15 to 30 minutes. Sodium bicarbonate helps only if acidosis is present. Salbutamol nebulization also shifts potassium, but it is slower. So remember, in hyperkalemia, calcium gluconate is the first thing you give. It is life-saving. Which of the following is not a cause of true hyperkalemia? Rhabdomyolysis, Addison's disease, acute tumor lysis syndrome, thrombocytosis. The correct answer is thrombocytosis. True hyperkalemia happens with tissue breakdown, such as rhabdomyolysis and tumor lysis, or adrenal insufficiency, as in Addison's disease. But in thrombocytosis, potassium leaks out of platelets after the blood sample is taken. This is an artifact called pseudo-hyperkalemia. Always interpret potassium levels carefully in patients with very high platelet or white blood cell counts. A 32-year-old woman on long-term diuretic therapy develops muscle weakness. ECG changes show flattened T waves, prominent U waves, and ST depression. What is the most likely electrolyte abnormality? Hyperkalemia, hypokalemia, hypocalcemia, hypomagnesemia. The correct answer is hypokalemia. Diuretics like furosemide and thiazide cause urinary potassium loss. Hypokalemia on ECG will reveal flattened or inverted T waves, prominent U waves, ST segment depression, prolonged QT interval, ventricular tachycardia, ventricular fibrillation, torsade de Pons. This ECG shows us the feature of hyperkalemia. This is the T wave inversion, prominent U wave, and ST segment depression. Which diuretic is most likely to cause hypokalemia? Spironolactone, furosemide, amiloride, eplerenone. Correct answer is furosemide. Loop diuretics like furosemide will cause potassium wasting in urine and hence lower the potassium level. Potassium sparing diuretics like spironolactone, amiloride, and eplerenone would actually raise the potassium levels.
Which is the correct sequence in managing severe hyperkalemia?
Calcium gluconate, insulin dextrose, salbutamol, dialysis if refractory. Insulin dextrose, calcium gluconate, salbutamol, dialysis. Calcium gluconate, salbutamol, dialysis, insulin dextrose. Dialysis, calcium gluconate, insulin dextrose, salbutamol. The correct answer is calcium gluconate, insulin dextrose, salbutamol, dialysis if refractory. Management of hyperkalemia is stepwise as we previously noted. You start with stabilizing the cardiac membrane. That's the role of calcium gluconate. Shift potassium into the cells. Insulin with dextrose, salbutamol will do this. Remove potassium from the body. Dialysis if refractory. Loop diuretics, potassium binders, that's the resins. Always stabilize first before lowering potassium levels. Which of the following is least likely in severe hypokalemia? Ventricular arrhythmias, muscle weakness, constipation, hyperreflexia. The correct answer is hyperreflexia. Severe hypokalemia affects muscle and nerve function. Common features include muscle weakness, cramps, constipation, ileus, and arrhythmias. But instead of exaggerated reflexes, hypokalemia usually causes reduced or absent reflexes. So, hyperreflexia is not expected in hypokalemia. Remember, low potassium, low muscle excitability. Which drug is most likely to cause hyperkalemia? Angiotensin converting enzyme inhibitor, thiazide diuretic, loop diuretic, beta agonist. The correct answer is angiotensin converting enzyme inhibitors. Angiotensin converting enzyme inhibitors like lisinopril, captopril, and so on actually reduce aldosterone, and this results in less potassium excretion, leading to hyperkalemia. Thiazide and loop diuretics will cause potassium loss and lead to hypokalemia. Beta agonists shift potassium into cells, actually lowering serum potassium. When replacing potassium in hypokalemia, which of the following statements is correct? IV potassium should be given rapidly for quick correction. Oral potassium is preferred in mild to moderate cases. IV potassium must always be diluted in 100 ml saline and infused over 15 minutes. Potassium replacement should not be given if the ECG is normal. The correct answer is oral potassium is preferred in mild to moderate cases. Oral potassium is safest and best for mild to moderate hypokalemia. IV potassium is reserved for severe or symptomatic cases and must be given slowly, about 10 to 20 millimoles per hour maximum, with ECG monitoring. Even if ECG looks normal, correction is still needed. A 65-year-old man presents with progressive dyspnea. Examination reveals reduced chest expansion, stony dull percussion, and absent breath sounds at the right lung base. Thoracentesis shows pleural fluid protein of 28 grams per liter, lactate dehydrogenase of 150 units per liter, and pleural to serum protein ratio of 0.4. Which of the following is the most likely diagnosis? Tuberculous pleural effusion, malignant pleural effusion, congestive heart failure related effusion, parapneumonic effusion. The correct answer is congestive heart failure related effusion. This is where Light's criteria comes in. Pleural fluid is an exudate if any of the following are true. Pleural fluid protein to serum protein greater than 0.5. Pleural fluid LDH to serum LDH greater than 0.6. Pleural fluid LDH greater than 2/3 of the upper limit of normal serum LDH. In this case, the absolute protein level is less than 30 grams per liter, which is in keeping with a transudate. The pleural fluid to serum protein ratio is less than 0.5, which is in keeping with a transudate. And the lactate dehydrogenase level is less than 200 units per liter, which is also in keeping with a transudate. And one of the most common cause of transudative pleural effusion is congestive heart failure. Every other option in the question will lead to an exudate. In pleural fluid analysis, which glucose value is most suggestive of empyema? 5 millimoles per liter, 4 millimoles per liter, 3.5 millimoles per liter, 2.5 millimoles per liter. The correct answer is 2.5 millimoles per liter. Low pleural fluid glucose, usually less than 3.3 millimoles per liter, occurs in empyema, malignancy, tuberculosis, rheumatoid arthritis, SLE. Bacteria and inflammatory cells consume glucose. So, very low pleural glucose will suggest empyema. Which of the following is a classic triad in MEG syndrome? Left pleural effusion, ovarian cysts, ascites. Right pleural effusion, ovarian fibroma, ascites. Bilateral pleural effusion, ovarian carcinoma, pericardial effusion. Unilateral pleural effusion, endometriosis, ascites. The correct answer is right pleural effusion, ovarian fibroma, and ascites. MEG syndrome is defined by right-sided pleural effusion, ovarian fibroma, ascites. All these resolve after tumor removal. It is important not to confuse with ovarian carcinoma, which also presents with ascites and effusion. But MEGS is specifically linked to fibroma, which is a benign tumor. During thoracentesis, for a large pleural effusion, the physician removes 2.5 liters of fluid. The patient develops acute dyspnea and cough afterward. Which complication most likely occurred? Pneumothorax, re-expansion pulmonary edema, empyema, hemothorax. The correct answer is re-expansion pulmonary edema. Removing greater than 1.5 liter at once can cause rapid re-expansion of a chronically collapsed lung. This leads to capillary leak and pulmonary edema, which presents as sudden dyspnea, cough, and hypoxia. Pneumothorax and hemothorax are also possible complications, but the classic scenario with large volume removal is re-expansion pulmonary edema. A 24-year-old tall teen male presents with sudden onset right-sided diuretic chest pain and mild dyspnea. He has no past medical history. Examination shows hyperresonance and reduced breath sounds on the right. Chest X-ray confirms small pneumothorax less than 2 centimeters. What is the most appropriate initial management? Immediate chest tube drainage, needle decompression, observation with supplemental oxygen, fluoridesis. The correct answer is observation with supplemental oxygen. This is a primary spontaneous pneumothorax in a healthy, tall, young man. If small, usually less than 2 centimeters, and patient is stable, observation and oxygen therapy is enough. Larger or symptomatic primary spontaneous pneumothorax pass a chest tube. Needle decompression is for tension pneumothorax, not stable primary spontaneous pneumothorax. Fluorodesis is for recurrent cases of pneumothorax. A patient develops sudden severe dyspnea, hypotension, tachycardia, and tracheal deviation to the left, following a stab wound to the right chest. What is the most appropriate next step? Urgent chest X-ray, immediate needle decompression at the second intercostal space mid-clavicular line, chest tube drainage at fifth intercostal space mid-axillary line, CT scan of the chest. The correct answer is immediate needle decompression at the second intercostal space mid-clavicular line. The patient has tension pneumothorax, which is a clinical diagnosis. Do not delay management waiting to do imaging. Immediate life-saving step, needle decompression at the second intercostal space, mid-clavicular line, just above the rib. Thereafter, you follow with a chest tube drainage at the fifth intercostal space, mid-axillary line. X-ray or CT scan would delay management, so this can be done later. Always treat tension pneumothorax clinically, not radiologically. Which of the following is the most common cause of a primary spontaneous pneumothorax? Rupture of apical subpleural blebs, rib fracture, central venous catheter insertion, COPD exacerbation. The correct answer is rupture of apical subpleural blebs. Primary spontaneous pneumothorax occurs in young, tall, thin men, which are otherwise healthy. The classic cause is the rupture of small apical subpleural blebs or bullae. Rib fractures and central lines would cause traumatic or iatrogenic pneumothorax. COPD causes secondary spontaneous pneumothorax and not primary. Which sign on supine chest X-ray is most suggestive of pneumothorax? Meniscus sign, deep sulcus sign, silhouette sign, air bronchogram. The correct answer is deep sulcus sign. In a supine patient, air doesn't rise to the top. Instead, it collects anteriorly and basally, making the costophrenic angle appear abnormally deep and lucent. This is the deep sulcus sign, classic for pneumothorax on supine chest X-ray films. Meniscus sign is seen in pleural effusion. Silhouette sign indicates loss of normal soft tissue air interface. Air bronchogram is seen in alveolar consolidation. Which combination defines Beck's triad? Hypotension, muffled heart sounds, elevated JVP. Hypertension, tachycardia, crackus. Chest pain, ST elevation, PRO depression. Wide pulse pressure, bounding pulses, murmur. The correct answer is hypotension, muffled heart sounds, elevated JVP. Beck's triad occurs in cardiac tamponade. It consists of hypotension as a result of impaired feeling, raised JVP from venous congestion, muffled heart sound as a result of the fluid around the heart. You may also see pulsus paradoxus and electrical alternance on ECG. A 28-year-old woman presents with persistent hypertension. Lab test shows hypokalemia and metabolic alkalosis. Which of the following is the most likely cause? Renal parenchymal disease, primary hyperaldosteronism, coarctation of the aorta, Cushing's syndrome. Correct answer is primary hyperaldosteronism. Primary hyperaldosteronism, which is Cushing's syndrome, It's characterized by hypertension, hypokalemia, metabolic alkalosis, which results from renal potassium and hydrogen ion loss. Renal parenchymal disease will cause hypertension but not hypokalemia. Coarctation of the aorta will cause differential pulses, not hypokalemia. Cushing syndrome may cause hypertension, but is also associated with central obesity, striae, and glucose intolerance. Which is the best first-line antihypertensive in a 52-year-old with type 2 diabetes mellitus and albuminuria? Angiotensin converting enzyme inhibitor, non-dihydropyridine calcium channel blockers, alpha blocker, thiazide alone. The correct answer is angiotensin converting enzyme inhibitor. In diabetes with nephropathy or proteinuria, the best drug is angiotensin converting enzyme inhibitors or the angiotensin receptor blockers. They reduce intraglomerular pressure, decrease albuminuria, and slow nephropathy progression. Thiazides lower blood pressure but do not protect the kidneys. Alpha blockers and non-dihydropyridine calcium channel blockers, they are not first line in this setting. Which of the following is the most preferred thiazide diuretic for hypertension due to its longer duration and superior cardiovascular outcomes? Hydrochlorothiazide, clothalidone, furosemide, indapamide. The correct answer is clothalidone. Clothalidone has a much longer half-life than hydrochlorothiazide. Clinical trials shows it gives better blood pressure control and lower cardiovascular risk. Indapamide is effective but less widely studied. Furosemide is a loop diuretic not used for routine hypertension. A patient has uncontrolled blood pressure despite being on lisinopril, amlodipine, and clothalidone. Which of the following is the next best step? Add spironolactone, increase clothalidone dose, add propranolol, switch lisinopril to losartan. The correct answer is add spironolactone. The patient has resistant hypertension. Blood pressure remains uncontrolled on 3 medications, which includes a diuretic. The recommended fourth-line agent is spironolactone, provided potassium level is less or equal to 4.5 millimoles per liter. Increasing thiazide dose has little effect. Switching ACE inhibitors to ARBs is not helpful. Beta blockers are not the first add-on in resistant hypertension. A 30-year-old woman, 24 weeks pregnant, presents with blood pressure 156 over 96 millimeters mercury. Which of the following antihypertensives is most appropriate? Methyl-dopa, enalapril, spironolactone, minoxidil. The correct answer is methyl-dopa. Safe antihypertensives in pregnancy include methyl-dopa, labetalol, nifedipine. ACE inhibitors and ARBs are contraindicated. They are teratogenic. Spironolactone is unsafe due to anti-androgenic effects. Minoxidil is rarely used and reserved for resistant hypertension, however not safe in pregnancy. A 42-year-old man presents with recurrent severe headaches, palpitations, and sweating. His blood pressure is 200 over 110 millimeters of mercury during an episode. Which investigation is most useful for confirming the suspected diagnosis? Plasma renin activity, plasma-free metanephrines, serum aldosterone renin ratio, echocardiography. The correct answer is plasma-free metanephrine. A triad of headache, palpitations, and sweating with paroxysmal hypertension is classic for Pheochromocytoma. The best test is plasma-free metanephrine or 24-hour urinary catecholamines. A 55-year-old man presents with severe chest pain, sweating, and blood pressure of 200 over 120 millimeters of mercury. ECG shows ST depression. What is the most appropriate BP lowering strategy? Reduce the mean arterial pressure by greater than 50% in the first hour. Immediate reduction of blood pressure to less than 120 over 80 millimeters of mercury. Lower blood pressure by 20 to 25% within the first hour using IV nitroglycerin. Start oral nifedipine capsule. The correct answer is lower blood pressure by 20 to 25% within the first hour using IV nitroglycerin. The patient has hypertensive emergency with acute coronary syndrome. The goal is to lower the mean arterial pressure by no more than 25% in the first hour using parenteral antihypertensives and gradually over 24 to 48 hours. IV nitroglycerin or IV labetalol is indicated in this case. Too rapid reduction will put you at risk of stroke, myocardial infarction, or renal failure. Oral nifedipine, either sublingual or bite and swallow, is dangerous, can lead to uncontrolled fall in blood pressure. Other antihypertensives indicated in hypertensive emergencies include nicardipine, hydralazine, esmolol, butyl-dopa, sodium nitroprusside, enalaprilate, clevidipine, and so on. Which of the following is essential for the definition of acute hepatic failure? Jaundice ascites, INR greater than 1, coagulopathy, INR greater than 1.5, and hepatic encephalopathy, elevated ammonia, grade 1 encephalopathy, and pre-existing cirrhosis, ALT greater than 1000 international units per liter, hypoglycemia, and renal failure. The correct answer is coagulopathy, INR greater than 1.5, and hepatic encephalopathy. Acute liver failure is characterized by an acute severe liver injury, coagulopathy, INR greater than 1.5, hepatic encephalopathy. All these happening within 26 weeks in individuals without pre-existing liver disease. Jaundice, ALT rise, and ammonia may be present but are not defining. So the key point is think acute liver failure when you have acute severe liver injury, INR greater than 1.5, hepatic encephalopathy in a patient with no pre-existing liver disease. So when a patient with an established condition like liver cirrhosis experiences an acute deterioration, the correct term is acute on chronic liver failure. A 45-year-old patient develops jaundice. 5 days later, he presents with grade 2 hepatic encephalopathy. According to the O'Grady's classification, how would this presentation of acute liver failure be categorized? Acute, subacute, hyperacute, fulminant. The correct answer is hyperacute. The O'Grady classification is based on the time interval between onset of jaundice and encephalopathy. It is hyperacute if the time from jaundice to encephalopathy is less than 7 days, acute 8 to 28 days, and subacute 29 to 12 weeks. In our patient, the time from jaundice to encephalopathy is 5 days, which makes it hyperacute. A 22-year-old male is admitted with acute liver failure due to paracetamol overdose. Which of the following sets of findings would meet the King's College criteria for urgent liver transplantation? INRO 5, creatinine 2.5 milligrams per dl, grade 2 encephalopathy. Arterial pH 7.4, INRO 6, grade 3 encephalopathy. Arterial pH 7.25, INRO 6.5, creatinine 3.0, and grade 2 encephalopathy. The correct answer is arterial pH 7.25. The King's College criteria are used to identify patients who need urgent liver transplantation. For paracetamol-induced acute liver failure, arterial pH less than 7.3 is a standalone indication. Our patient has 7.25, which makes it the correct answer because it's less than 7.3. Or all three, INR greater than 6.5, creatinine greater than 3.4, and grade 3 or 4 encephalopathy. For the non-paracetamol acute liver failure, INR greater than 6.5 is a standalone indication, or 3 of age less than 10 greater than 40, jaundice to encephalopathy interval greater than 7 days, INR greater than 3.5,
Serum bilirubin greater than 17.5 milligrams per deciliters,
and drug-induced acute liver failure, or factor 5 level less than 15%, and grade 3 or 4 encephalopathy. That's another standalone criteria. A patient presents with acute liver failure in a rural, resource-limited setting in a developing country. Which of the following is the most probable etiology? Paracetamol toxicity, autoimmune hepatitis, acute viral hepatitis, mushroom poisoning. Correct answer is acute viral hepatitis. In developed countries like the US and UK, the leading cause is paracetamol overdose. In developing countries, leading cause is acute viral hepatitis, most commonly A, B, and E. Autoimmune and mushroom poisoning are much less common causes. This slide outlines the various causes of acute hepatic failure, from infectious to drugs, toxins, autoimmune, vascular, pregnancy-related, and idiopathic. Create time to look at it. A patient presents with rapidly developing ascites and acute liver failure. Which investigation is most crucial to evaluate for a potential vascular cause like Budd-Chiari syndrome? CT scan of the brain, serum ceruloplasmin level, abdominal ultrasound with Doppler of hepatic veins, anti-smooth muscle antibody tests. The correct answer is abdominal ultrasound with Doppler of hepatic veins. Budd-Chiari syndrome is caused by the obstruction of hepatic venous outflow. An abdominal ultrasound with Doppler imaging is the primary non-invasive investigation to assess blood flow in the hepatic veins and inferior vena cava. CT scan of the brain is irrelevant in this case. Serum ceruloplasmin is for Wilson's disease, and anti-smooth muscle antibody is for autoimmune hepatitis. Which of the following best describes type B hepatic encephalopathy? Encephalopathy resulting from acute liver failure, encephalopathy due to cirrhosis with portal hypertension, encephalopathy due to portal systemic bypass with intrinsic liver disease, a subclinical form detected by only neuropsychological testing. The correct answer is encephalopathy due to portal systemic bypass without intrinsic liver disease. The etiologic classification of hepatic encephalopathy include type A, type B, and type C. Type A due to acute liver failure, Type B due to portosystemic bypass without intrinsic liver disease. Type C due to cirrhosis with portal hypertension or portosystemic shunt. Take note: A for acute, B for bypass, and C for cirrhosis. In the pathophysiology of hepatic encephalopathy, ammonia crosses the blood-brain barrier and is taken up by astrocytes. What is the immediate metabolic consequence of this process within the astrocyte? Conversion of ammonia to urea via the urea cycle, synthesis of glutamine from glutamate leading to osmotic stress, direct inhibition of GABAergic neurotransmission, accumulation of manganese causing Parkinsonian features. The correct answer is synthesis of glutamine from glutamate leading to osmotic stress. In liver failure, ammonia bypasses detoxification and enters the systemic circulation. It crosses the blood-brain barrier and taken up by astrocytes. In the astrocytes, ammonia combines with glutamate to form glutamine, catalyzed by glutamine synthesis. Glutamine is osmotically active, causing the astrocyte to swell and cause cerebral edema. This also depletes glutamate, reducing excitatory neurotransmission. A 58-year-old male with cirrhosis is brought to the emergency department by his family. He has been increasingly lethargic and drowsy, but is easily rousable. On examination, he is disoriented to time and place, and a prominent flapping tremor is elicited. According to the West Haven criteria, what is the grade of his hepatic encephalopathy? Grade 1, 2, 3, or 4? The correct answer is grade 2. This is the West Haven grading of hepatic encephalopathy. There is usually a subclinical grade, the minimal hepatic encephalopathy. Then you have 1 to 4, which ranges from mild confusion, poor concentration, euphoria, disordered sleep pattern in grade 1. In grade 2, you have marked confusion, disoriented in time and place. They are drowsy but easily rousable. They are lethargic and have flapping tremor, hysterexis. In grade 3, they have marked confusion, gross disorientation. They are stuporous but arousable with flapping tremor. In grade 4, they are comatose. Lactulose is the first-line therapy for hepatic encephalopathy. Its primary mechanism of action involves which of the following? Direct neutralizing ammonia in the bloodstream, increasing urease producing gut flora, acidifying the colon to trap ammonia as ammonium, acting as a benzodiazepine receptor antagonist. The correct answer is C, acidifying the colon to trap ammonia as ammonium. Lactulose is a non-absorbable disaccharide that is metabolized by colonic bacteria into acidic byproducts. This lowers the colonic pH, which promotes the conversion of ammonia, which is absorbable, into non-absorbable ammonium, trapping it in the gut for excretion. It also acts as an osmotic laxative, increasing stool frequency and less ammonia absorption. A patient with chronic hepatic encephalopathy develops Parkinsonian features. An MRI of the brain is most likely to show T1 hyperintensity in which of the following structures due to mineral deposition? Hippocampus, cerebral cortex, cerebellum, globus pallidus. Correct option is globus pallidus. In chronic hepatic encephalopathy, manganese deposition occurs in the basal ganglia. The MRI shows T1 hyperintensity in the globus pallidus. Clinically, patients develop Parkinsonian features such as tremor, rigidity, and bradykinesia. A 65-year-old patient with decompensated cirrhosis is being managed for recurrent episodes of overt hepatic encephalopathy despite optimal lactulose therapy. Which of the following medications is the most appropriate next step to add for secondary prophylaxis? Neomycin, rifaximin, metronidazole, flumaxenil. The correct option is B, rifaximin. Rifaximin is a non-absorbable antibiotic that reduces ammonia-producing gut flora. It is used with lactulose to prevent recurrence and is preferred over neomycin and metronidazole due to a better safety profile. Flumaxenil is only used in benzodiazepine-induced hepatic encephalopathy. What is the characteristic histological finding in the brain of a patient with hepatic encephalopathy, reflecting astrocyte dysfunction and cerebral edema? Lewy bodies, neurofibrillary tangles, Alzheimer type 2 astrocytosis, perivascular coughing. The correct option is Alzheimer type 2 astrocytosis. The hallmark histologic marker of hepatic encephalopathy is Alzheimer's type 2 astrocytosis. These astrocytes are swollen with pale enlarged nuclei, as you can see. It reflects ammonia-induced astrocyte dysfunction and cerebral edema. Other options such as Lewy bodies, the tangles, and perivascular coughing relate to other diseases. For example, the Lewy bodies is associated with Parkinson's disease, neurofibrillary tangles with Alzheimer's dementia, perivascular coughing associated with viral encephalitis. A patient with cirrhosis presents with progressive confusion and hysterexis. Which precipitant is most likely to have triggered the hepatic encephalopathy? Hyperkalemia, upper gastrointestinal bleeding, hypothyroidism, long-term lactulose use. The correct option is upper gastrointestinal bleeding. This slide shows the various precipitants of hepatic encephalopathy, which include increased nitrogen load from GI bleeding, constipation, high protein diet, electrolyte abnormalities, hypokalemia, hyponatremia, medication, sedative, opioid, diuretics, infections like spontaneous bacterial peritonitis, dehydration from vomiting diarrhea or large volume abdominal parasitensis, transjugular intrahepatic photosystemic shunt, hepatocellular carcinoma. However, in this case, GI bleeding is the most common acute trigger due to nitrogen absorption from blood breakdown. Which lab pattern best indicates a cholestatic pattern of liver injury? Markedly elevated ALT, AST, predominant increase in ALP and gamma GT, isolated hypoalbuminemia, normal bilirubin with INR of 3. The correct option is B, predominant increase in ALP and gamma GT with mild transaminase rise. This table shows the different patterns of liver injury. Hepatocellular injury, elevation of alanine and aspartate transaminase. Cholestatic liver injury, increase in ALP and gamma glutamate transferase, as we can have in biliary obstructions. For a mixed picture, you have elevation of ALT, AST, and ALP. This is common in drug-induced liver injury, then biliary involvement plus viral hepatitis. For synthetic dysfunction, you have reduction in albumin and increased INR. Which test pattern most suggests portal hypertension as a cause of ascites? Serum ascites albumin gradient of less than 1.1, serum ascites albumin gradient of greater than 1.1 gram per dl, pleural fluid triglyceride of greater than 110 milligrams per deciliter, serum ferritin greater than 1000 nanogram per ml. The correct option is B. Serum ascites albumin gradient greater or equal to 1.1 gram per deciliter. The serum ascites albumin gradient is the most reliable test to differentiate portal hypertensive versus non-portal hypertensive ascites. If it is greater than 1.1 gram per deciliter, it means portal hypertension is present. So the causes of the ascites could be cirrhosis, Budd-Chiari syndrome, alcoholic hepatitis. If it is less than 1.1 gram per deciliter, it means there is no portal hypertension. So you consider causes like TB peritonitis, pancreatitis, and so on. If an ascitic tap shows a polymorphonuclear count of greater or equal to 250 cells per macroliter, what is the best next step? Observe and repeat in 48 hours. Start IV third generation cephalosporin. Start diuretics only. Immediate paracentesis to remove all fluid. The correct option is B. Start IV third generation cephalosporin. Spontaneous bacterial peritonitis is diagnosed when the polymorphonuclear count is greater or equal to 250 cells per microliter in ascitic fluid. Even if culture is negative, still treat empirically. First line to treat spontaneous bacterial peritonitis is IV third generation cephalosporin like cefotaxime, ceftriaxone. Diuretics don't treat infection. Paracentesis is diagnostic, not therapeutic in this case. Oral norfloxacin or ciprofloxacin can be used as secondary prophylaxis for survivors of spontaneous bacterial peritonitis. Which NSAID-related mechanism most contributes to ulcer formation? Inhibition of cyclooxygenase 2 enzyme, inhibition of prostaglandin synthesis, increase in gastrin secretion, enhanced mucosal bicarbonate secretion. The correct option is B. Inhibition of prostaglandin synthesis via cyclooxygenase 1 pathway. The non-steroidal anti-inflammatory drugs block cyclooxygenase 1, thereby reducing prostaglandins. Prostaglandins normally protect gastric mucosa by maintaining blood flow, mucus, and bicarbonate secretion. With cyclooxygenase 1 inhibition, this protection is lost, leading to ulcer formation. Cyclooxygenase 2 inhibition is less ulcerogenic. Non-steroidal anti-inflammatory drugs also cause direct epithelial toxicity, but the main mechanism is loss of prostaglandins. A 36-year-old man with recurrent multiple peptic ulcers and diarrhea is suspected of having Zollinger-Ellison syndrome. Which test is most appropriate? Endoscopic biopsy, serum gastrin level, urea breath test, abdominal ultrasound. The correct option is B. Serum gastrin level. Zollinger-Ellison syndrome is a gastrin-secreting tumor, gastrinoma. It leads to massive acid hypersecretion, which leads to multiple refractory ulcers and diarrhea. Serum gastrin measurement is the key test. Urea breath test is for Helicobacter pylori and not Zollinger-Ellison syndrome. Endoscopy may show ulcers but does not confirm Zollinger-Ellison syndrome. A patient with duodenal ulcer has persistent pain despite standard triple therapy, proton pump inhibitor, clarithromycin plus amoxicillin. What is the next best step? Repeat same triple therapy for another 2 weeks. Perform testing for eradication and if positive, give second line therapy. Assume pain is functional and stop treatment. Start lifelong low-dose PPIs without testing. The correct option is perform testing for eradication and if positive, give second-line therapy. After first-line treatment, always confirm eradication with urea breath test or stool antigen test. If still positive, it means the first-line therapy has failed. Therefore, start second-line regimen. Could be bismuth-based quadruple therapy or the levofloxacin-based therapy. Repeating the same triple therapy rarely works due to resistance. Functional pain is a diagnosis of exclusion. Which of the following is true regarding Helicobacter pylori? It is causally linked with PUD but not gastric B-cell lymphoma. Gram-positive bacilli, spiral-shaped, multiflagellate, microaerophilic, and urease-producing. Can transform to a coccoid form in its active state, damages the mucosa via inflammation and urease activity. The correct option is D. Damages the mucosa through inflammation and urease activity. The following are facts about Helicobacter pylori. It's gram-negative bacilli, spiral-shaped, microaerophilic, slow-growing, highly motile, multiple flagella, and urease-producing. It can transform to a coccoid form in its dormant state, which facilitates its survival in adverse conditions. It damages the mucosa via inflammation and urease activity. Transmission is by fecal-oral, oral-oral route, and could be iatrogenic. It is causally linked with peptic ulcer disease, gastritis, gastric adenocarcinoma, and gastric B-cell lymphoma. It causes about 70% of gastric ulcers and 95% of duodenal ulcers. Which of the following is the most sensitive and specific non-invasive test for Helicobacter pylori? Stool antigen test, urea breath test, rapid urease test, serum antibody tests. The correct option is urea breath test. The urea breath test is the gold standard non-invasive test for Helicobacter pylori. The stool antigen test is also reliable, especially for follow-up. Helicobacter pylori serology detects antibody and is not reliable for current infection. It stays positive even after eradication. Rapid urease test requires endoscopy, so it's an invasive test. Other invasive tests include histology and culture because it involves endoscopy and biopsy. A 60-year-old smoker with melena and weight loss should raise suspicion for uncomplicated duodenal ulcer, gastric outlet obstruction, malignant gastric ulcer, gastroesophageal reflux disease. The correct option is C. Malignant gastric ulcer. Alarm features are red flags requiring urgent endoscopy. In this case, weight loss and melena raise a suspicion for a gastric malignancy. Alarm features include recent onset of symptoms in patients greater than 45 years, anemia, unexplained weight loss, recurrent vomiting, melena, hematemesis, dysphagia. Gastric ulcers require biopsy to exclude cancer, unlike duodenal ulcers, which are rarely malignant. The best test to confirm Helicobacter pylori eradication post-treatment is H. pylori IgG serology, stool antigen test, rapid urease test, gastrin levels. The correct option is stool antigen test. After treatment, eradication is confirmed by the stool antigen test or the urea breath test. Both are non-invasive tests. IgG serology is not useful because antibodies remain positive long after infection. The rapid urease test needs endoscopy, hence not routinely used for follow-up. Gastrin levels are indicated in Zollinger-Ellison syndrome and not to confirm H. pylori eradication. Which of the following imaging findings is most consistent with a perforated peptic ulcer? Dilated stomach with retained food, free air under the diaphragm on chest X-ray, thickened gastric folds on CT scan, hyperdense lesions in the pancreas. The correct option is free air under the diaphragm on chest X-ray. Perforation is one of the complications of peptic ulcer disease and could present as sudden severe abdominal pain with signs of peritonitis. The classic imaging findings include free subdiaphragmatic air on erect chest X-ray. Dilated stomach is seen in gastric outlet obstruction. Thickened folds are seen in gastritis or infiltrative disease. Hyperdense pancreatic lesion is not relevant in this case. A 34-year-old presents with acute unilateral lower motor neuron facial nerve palsy and no vesicles. What is the best initial therapy? Oral prednisolone started within 72 hours. IV acyclovir alone. No treatment needed. Immediate MRI of the brain. The correct option is oral prednisolone started within 72 hours. Bell's palsy is idiopathic acute lower motor neuron facial nerve palsy with no vesicles or any other neurological deficits. The best treatment is to start oral corticosteroids within 72 hours. This improves recovery and reduces long-term complications. Antiviral are not first line unless herpes zoster is suspected. MRI is not required unless patient presents with atypical features. Other management plans include eye care, like using lubricating drops or ointment, eyelid taping at night, and also consider a moisture chamber if incomplete eye closure. Which finding supports a lower motor neuron facial nerve palsy? Forehead sparing, loss of forehead wrinkling on the affected side, spasticity of contralateral limbs, tongue deviation to the opposite side. The correct option is loss of forehead wrinkling on the affected side. In lower motor neuron facial nerve palsy, as in Bell's palsy and Ramsay Hunt syndrome, the entire ipsilateral side of the face is weak. This happens because the lower motor neuron lesion cuts off both upper and lower facial nerve supply to that side. So the patient presents with loss of forehead wrinkling, inability to raise the eyebrow, drooping of the mouth, incomplete eye closure, and flattened nasolabial fold. However, in upper motor neuron facial nerve palsy, the forehead is spared because upper facial muscles get bilateral cortical inputs. Which clinical feature points to Ramsay Hunt syndrome rather than Bell's palsy? Sudden facial weakness, vesicular rash in the external ear canal, loss of taste on the anterior two-thirds of the tongue, inability to fully close the eye. The correct option is vesicular rash in the external ear canal. Ramsay Hunt syndrome occurs as a result of reactivation of the varicella zoster virus in the geniculate ganglion of the facial nerve. The hallmark feature is a painful vesicular rash in the external ear canal, the pinna, or the palate, often accompanied by facial palsy. The key feature distinguishing it from Bell's palsy is the painful vesicular rash in the external ear canal. Both Ramsay Hunt and Bell's palsy would cause lower motor neuron facial nerve palsy and will present with sudden facial weakness, loss of taste on the anterior two-thirds of the tongue, and inability to fully close the eyes. A 25-year-old woman presents with dysuria, frequency, and suprapubic discomfort. She has no fever or flank pain. Which is the most likely diagnosis? Pyelonephritis, cystitis, urethritis, renal abscess. The correct option is cystitis. Cystitis is lower urinary tract infection and presents with dysuria, frequency, suprapubic pain, but no systemic symptoms. In pyelonephritis, you have fever, flank pain, and systemic symptoms. Urethritis is often STI related, like gonorrhea or chlamydia. Which of the following is considered a complicated UTI? UTI in a healthy young woman, UTI in pregnancy, UTI with dysuria and frequency only, first time UTI in a child greater than 12 years. The correct option is UTI in pregnancy. Complicated UTIs occur in the presence of risk factors such as male sex, pregnancy, catheters, urinary obstruction, diabetes mellitus, immunosuppression. Uncomplicated UTI occurs in otherwise healthy non-pregnant women with no risk factors. A 45-year-old man with diabetes presents with fever, chills, and flank pain. Urine culture shows Proteus mirabilis. Which complication is he at risk of? Renal stones, bladder cancer, glomerulonephritis, interstitial cystitis. The correct option is renal stones. Proteus species are urease positive. They hydrolyze urea to ammonia, which results in alkaline urine. This leads to precipitation of magnesium ammonia phosphate, which leads to the formation of struvite stones, also called the staghorn calculi. These stones can perpetuate infection and cause urinary obstruction. Other options like bladder cancer, glomerulonephritis, interstitial cystitis are not directly related to Proteus. A woman has a urinary tract infection treated successfully. 6 weeks later, she develops a new UTI with a different organism. This is relapse, reinfection, persistent bacteriuria, chronic pyelonephritis. The correct option is reinfection. A recurrent UTI is 2 or more UTIs in 6 months or 3 in a year. Relapse is recurrence of the UTI by the same organism within 2 weeks after treatment, usually due to incomplete eradication. Reinfection is a new infection by a different organism, usually weeks or months later. Persistent bacteriuria is continuous presence of bacteria despite treatment. Which antibiotic is first-line therapy for uncomplicated cystitis in most women? Ciprofloxacin, amoxicillin, nitrofurantoin, gentamicin. The correct option is nitrofurantoin. Nitrofurantoin is the preferred first-line drug for uncomplicated cystitis. Alternatives are trimethoprim or fosfomycin, depending on the resistance pattern. Fluoroquinolones are reserved due to resistance and adverse effects. A 32-year-old pregnant woman at 18 weeks is found to have asymptomatic bacteriuria on routine screening. What is the best management? No treatment needed. Start oral antibiotics. Repeat urine culture in 2 weeks only. Treat only if symptoms develop. The correct option is start oral antibiotics. Asymptomatic bacteriuria must always be treated in pregnancy. It is the presence of significant bacteriuria, that is greater than 10 to power 5 colony forming units per ml of urine, without symptoms. Untreated, it's a high risk of pyelonephritis, preterm labor, and low birth weight. Safe options include amoxicillin, nitrofurantoin, or cephalexin. In non-pregnant women, treatment isn't always needed unless risk factors are present. Which of the following organisms is most associated with UTI in young sexually active women? Staphylococcus saprophyticus, E. coli, Proteus mirabilis, Klebsiella pneumoniae. The correct option is Staphylococcus saprophyticus. E. coli is the most common cause of UTI overall in about 70 to 95% of cases. But in young sexually active women, Staphylococcus saprophyticus is strongly associated. It is a gram-positive coagulase negative staph. Which scoring system is commonly used to assess the risk and need for intervention in acute upper gastrointestinal bleeding? COP65 score, raw cause score, acute physiology and chronic health evaluation 2, well score. The correct option is raw cause score. The raw cause score assesses the risk of rebleeding and mortality after endoscopy in upper gastrointestinal bleeding. Another score, Glasgow-Blatchford, predicts the need for intervention like transfusion or endoscopy. Both are validated tools for upper gastrointestinal bleeding. COP65 is for pneumonia. The acute physiology and chronic health evaluation 2 score is for ICU severity. The well score is for deep venous thrombosis or pulmonary embolism. The last question in this series. A 63-year-old man presents with melena. Endoscopy reveals a bleeding duodenal ulcer. Which of the following is part of endoscopic hemostatic therapy? IV telepressin, epinephrine injection plus hemoclip placement, oral sucralfate, tranexamic acid infusion. The correct option is B, epinephrine injection with hemoclip placement. Endoscopic therapy for peptic ulcer bleeding includes adrenaline or epinephrine injection, thermal coagulation, mechanical therapy as in clips and bands. IV telepressin is used for variceal bleeding, not peptic ulcers. Sucralfate aids healing but not hemostasis. Tranexamic acid is not routinely used in gastrointestinal bleeding. This brings us to the end of this 60 questions internal medicine revision session. I hope you found the explanation clear, detailed, and helpful for both your exams and clinical practice. Remember, the key to success is not just memorizing the answers, but understanding the reasoning behind each choice. If you enjoyed this session, don't forget to like this video, share it with your colleagues, and subscribe to the channel for more high-yield medical revision content. Thank you for watching and best wishes in your exams and future medical practice.